John Major and the Private Finance Initiative. The next step in the privatisation of the NHS occurred in 1993, with the Tory government's inauguration of the Private Finance Initiative. This was the creation of Peter Lilly, who wished to open the health service up to further private investment. Major's government announced that it would not fund the construction of any more hospitals until the NHS had first looked at using private funding. The private companies involved in the deal would build the hospitals and then lease them back to the NHS. The companies would also continue to run the non-medical services such as portering, cleaning and catering. This policy was initially attacked by Labour, which was then in opposition. After it won the 1997 election, however, it abandoned its earlier stance and embraced and expanded the policy. So much so that in 2000 it announced that private projects worth 20 billion would be funded through PFI by 2003. Rather than providing more money to the cash-strapped NHS and making the health service more efficient, the Private Finance Initiative has had the opposite effect. In order to ensure that the private firms running the scheme make healthy profits, the health trusts commissioning them will actually have to close hospitals, and those built will have fewer beds. It was estimated that the first 14 hospitals to be built under the scheme by New Labour would lose 3,700 beds. The health trusts involved in the scheme in England would lose 26% of their beds, while those north of the border in Scotland would lose 30%. The nursing budget was expected to be slashed by between 10 and 20%. A consultancy study commissioned by the Department of Health and the Health Trust estimated that for every 200 million spent on privately financed hospitals, 1,000 doctors and nurses would have to be lost. Most PFI schemes drawn up by 2000 involved the closure of all except one hospital belonging to the health trusts involved. The health trusts would also have to ration the treatments available, and concentrating on treating the easier cases and reducing the numbers of prolonged and difficult treatments. Accidents and emergency and maternity wards will be scaled down. Those who can afford to do so would be encouraged to purchase private treatment through insurance. Furthermore, the costs of such schemes tend to rise massively after the first estimate. The British Medical Association found that costs rose by an average of 72% between the first proposal by a consortium and the closure of the final deal. Legislation passed in September 1997 also demands that cuts to the NHS budget should be made from medical staff and the treatment of patients and not payments to the private companies running the hospitals. British captains of industry and the CBI have welcomed the PFI and demanded that they have increasing control over it. Sir Alistair Morden, who was a member of the government's private finance panel and a co-chairman of Eurotunnel, declared that PFI was the Heineken of privatisation, taking the private sector to the parts of the government machine not reached by previous privatisations. The CBI has also lobbied intensively for PFI schemes to be expanded and for industry to be given control of the scheme. They specifically demanded that the private finance panel, set up by the Treasury, should be dissolved as it contained too many civil servants. It was to be replaced with a new task force whose members would all be heads of private companies. New Labour complied and the panel scrapped and replaced with a task force headed by merchant banker Adrian Montague, responsible for the Channel Tunnel and the privatisation of British Rail, and whose 8 other members were also leading industrialists. The private sector gained even more control of the task force in 2000 when it was privatised. The result of this has been that an increasing number of PFI hospitals are experiencing financial difficulties due to the debts that they have built up through the Private Finance Initiative. So much so that Monitor was building up a fund of £300 million to spend on special administrators to be sent into as many as 60 failing trusts. But still the PFI, derided in opposition by the Tories, still continues under the Conservative Chancellor George Osborne. I wrote this when David Cameron was in power. New Labour and managed care. Tony Blair's New Labour was as keen as the Tories to privatise the NHS. Alan Milburn wanted to reduce the NHS to a logo attached to purely private healthcare providers. New Labour were particularly impressed by a piece in the British Medical Journal in 2002, claiming that Kaiser Permanente a California-managed private healthcare provider, was achieving outstanding results and was more efficient than the NHS. In fact, it wasn't. It was actually far more inefficient. Managed care organisations and the wider health maintenance organisations were extremely profitable and had considerable support among the bankers in Wall Street. They were also becoming increasingly expensive, and the American domestic market was glutted with them. The American government and industry was therefore trying to export them overseas, and especially into countries with state healthcare schemes. As any attempt to privatise the health service directly and openly would lead to Labour losing the election, they decided to reform the NHS by stealth. The NHS will be separated into its different components, with particular focus on separating insurance from delivery, and then further reformed into US-style managed care organisations. As a result, hospitals were taken out of the NHS and made self-governing as foundation trusts. They were supervised by an independent body and monitor. Instead of offering a full range of services, they were given a licence to buy monitor to offer only a limited range. They could borrow money privately and make deals with private healthcare companies. If they ran into financial difficulties, however, they would not be bailed out by the Department of Health, but would either go bankrupt or be handed over to a private healthcare company to run. The NHS trusts held their board meetings in public, published the minutes of their board meetings, and were legally obliged to consult the public on major changes. It is the opposite with foundation trusts. They can meet secretly, do not have to publish their board papers, and need only to refer to the regulator monitor before making important decisions. NHS hospital managers were responsible to the Secretary of State, who in turn was responsible to Parliament. The new foundation trusts were neither responsible to the Health Secretary or to NHS management, but only to monitor, which has very little power to intervene. The government also introduced another reform from America, payment by results. Instead of receiving a lump sum, hospitals were to be paid for each patient, who received treatment according to fixed rates of service. The government also introduced into the NHS private independent sector treatment centres based on the US ambulatory care centres. These were supposed to use their own staff, but in practice depended on the NHS for staffing. A clash with NHS consultants in 2003 over new contracts was also seen as an opportunity to impose further privatisation. Dr. Penny Dash, a Director of Strategy in the NHS and one of the architects of the 2000 NHS plan, viewed the conflict as an opportunity to encourage consultants and doctors to form their own private companies outside the NHS, which would sell their services back to it. Dash succeeded. A survey conducted in August 2003 found that only 23% of consultants wished to remain in the NHS. The rest were considering moving abroad or forming their own private companies modelled on barristers' chambers. The government also began privatising GP services by giving them a new contract, allowing them to opt out of after-hours service. 90% of GPs did so. The government therefore turned to government outsourcing companies such as Serco and Harmony to provide these services. They also introduced the alternative provider medical services, allowing the primary care trusts to commission healthcare cover for their areas from the big private companies such as United Healthcare Group, Care UK and Atos Origin. These employed doctors on fixed salaries and all provided an out-of-hours service. In 2007-08, the government also began moving all the doctors' surgeries into polyclinics, which were also called community health centres, walk-in centres and a number of other terms. They also provided other forms of providing primary care, involving Asda, Tesco or Virgin. 227 GP surgeries were thus being run by private companies by 2010. Among the 9 leading firms were Care UK and Virgin Care. The next phase of the plan to introduce US-style managed care into the NHS occurred in 2006, with the creation of a national leadership network. This included 150 policy makers, management consultants, NHS trusts, and the executives of private health companies, professional leaders, and regulators and doctors. This duly produced the policy document Strengthening the Local Services, the Future of the Acute Hospital, which recommended further reforms on the pattern of managed care. The government was determined to expand the polyclinics, which were to be privately financed, They would also probably be privately owned and operated. 140 of these clinics were set up, although the programme was effectively ended by the debt crisis of 2008. New Labour had planned that the establishment of the ISTCs would lead to the main private hospital chains entering the NHS market. It succeeded, and by 2011 private hospital chains such as Nuffield, BMI, Spire and Ramsay were carrying out NHS treatments worth £1 billion. NHS hospitals were also facing an acute funding crisis. By 2011, 60 NHS hospitals run by 20 trusts were in financial difficulties. In June 2012, Candice Emerson, one of the leading members of the National Policy Network and a Deputy Policy Director of the King's Fund, said in a breakfast seminar that one way to solve this problem would be to have these hospitals taken over by the private chains. More GPs were also forming their own private companies, while the private healthcare chains did indeed show considerable interest in taking over the running of some of the 1 in 5 NHS hospital trusts that were now in difficulty. New Labour and the new Conservative government elected in 2010 also wanted to reintroduce private health insurance into British healthcare after such schemes were replaced by the NHS. Blair and New Labour set about doing this through the framework for procuring external support for commissioners. Under this scheme, the major health insurance companies from Britain and America, and also the multinational companies which took in healthcare work, would collaborate with the PCTs in making all decisions about the provision of care. Companies such as Aetna, Bupa, United Health and McKinsey would be responsible for service planning, reconfiguring of services, controlling referrals and marketing. New Labour also took another step towards replacing state healthcare with private insurance in 2009 with the introduction of personal care budgets. This was a provisional scheme in which 68 budgets for personal health projects awarded to 75 PCTs. It appears highly likely that funding for such budgets will be limited and that patients will be expected to supplement the state budget through private insurance. And the private health insurers looked forward to this. AXA PPP's commercial director announced in March 2009, "We welcome the DH's decision to allow patients to complement their NHS treatment with privately funded care. It's a big step in the right direction of giving patients greater choice over their healthcare provision." Indeed, the right-wing think tank Civitas has lamented the fact that the majority of British citizens did not, as Bevers expected in his report, purchase private health insurance in addition to the state provision. They therefore recommended that people should be forced to take out personal welfare savings accounts formed through compulsory enrolment in private health insurance from which they would pay the cost of their medical care. Under this scheme, the state would only be required to pay if the costs went above a certain amount. They admitted, however, that at this point in time this would be a step too far for the British public and politicians. David Cameron and the Conservatives. David Cameron and the Conservatives continued the creeping privatisation of the NHS, which began with Thatcher with Andrew Lansley's Health and Social Care Act of 2012. This piece of legislation completes the institutional changes to permit the final privatisation of the NHS into a system of private health care modelled on that of the US. But their intentions to introduce these reforms were and are kept well hidden behind a very carefully constructed facade to make it appear as if they were doing the opposite. In the run-up to the 2010 election, the Tories declared that they would definitely not cut the health services budget, nor would they reorganise it, as previous administrations had done. Indeed, from 2006 onwards, Cameron and Lansley were posing as champions of the NHS, campaigning to save it from the cuts and closures being inflicted by Blair. They announced that they would end the closures of accident and emergency departments and maternity services, and campaigned to keep a few selected hospitals in traditional Tory seats open. Within 3 months of getting into number 10, these policies were dropped, the hospitals, A&E departments and maternity services closed, and a new reorganisation of the NHS announced. Well, as someone once said, the Conservative Party is an organised hypocrisy. There were a variety of motives behind the coalition's movement of the commissioning process from the PCTs to GPs. One of the main reasons was that the private insurance companies in the FESC were frustrated by the lack of work they were actually getting in practice. GPs were seen as far more willing to commission care from private companies. The coalition also continued the development of the federation model GP groupings, which was carried out from 2007 and 2011 by the Royal College of General Practitioners under its chairman, Professor Steve Field. There are a number of ways this would go, and it is as yet unclear how it will develop. It is possible that they will become similar to American IPAs, unfortunately that does not stand for India Pale Ale, which manage private patient care under a fixed budget through contracts with private insurance companies. In 2010, the UICGP, the King's Fund and the Nuffield Trust produced a toolkit to explore the different possible options. These included private companies with shares, to limited liability partnerships and community interest companies. At the time it was produced, 15% of federations were working with private healthcare companies.